I'm thrilled to say today that there is a new option for patients with relapsed AML, and in particular a mutationally targeted therapy for a subset of patients that have the most aggressive subtype of this disease. One thing that I've known is that if we have good targeted therapy, then we potentially have good options for patients, and I'm really thrilled to see the payoff of many years of work helping to develop drugs for this population in the form of an FDA approval of a targeted drug for them. I'm very excited about the recent FDA approval. We have hoped for a very long time to have a single-agent FLT3 inhibitor to treat all our patients with relapsed refractory AML, whether they had a FLT3 ITD or a FLT3 TKD or both. It has been a long time coming to have a drug that is active in the clinic in the outpatient setting, that is a targeted drug for this hard-to-treat population that has really dismal outcomes with standard therapy. We've learned a lot about the genetics of leukemia and the biology of leukemia really in the last few years. One of the exciting things that happened in 2017 was not only that new drugs were approved, but the drugs that were approved were for specific subtypes of AML. So I think it really took a long time to come up with smart drugs that really did their job well. And it's been exciting in the last few years to start seeing that not only are there drugs for patients with FLT3 mutations, but drugs that can really work by inhibiting FLT3 and have been really validated to do so. Should we be using next-generation sequencing in every patient? Does it give us useful information? And I think the answer is yes. We can find many mutations in patients that we say we don't have a treatment for that, but that might give us information about prognosis. So I think it's important to characterize the patient's optimal treatment based on genetic mutation complement. And there are good data to say that we can do that. One additional advantage to sending a FLT3 mutation test at relapse is that the mutation status can change from diagnosis to relapse. That's not all that common, but it does happen where patients don't have a FLT3 mutation when they're first diagnosed, but when they relapse, they've acquired it. And maybe that even was the reason why the leukemia grew back, was the presence of the mutation. That actually identifies a patient who we wouldn't know could benefit from a FLT3 inhibitor, but in this context really can. And similarly, patients who had a FLT3 mutation when they were first diagnosed, not very commonly, but sometimes will not have the FLT3 mutation present at the time of relapse. So it's important to know, because if they don't have a mutation, we don't know how much they'll benefit from this therapy, and that's a reason that they might choose a different therapy. For many years, our approach to treating patients with AML who had FLT3 mutations present at relapse was no different than treating patients who didn't have this mutation. They would be treated with chemotherapy at an intensity appropriate to the patient. What's different now that we have FLT3 inhibitors is we are not using chemotherapy to treat these patients. AML is a disease that very few people experience just themselves. It affects a whole family. It affects couples, parents and children. It's a life-altering diagnosis where you really often have to put your life on hold in order to treat it effectively. And so a caregiver can be really important in terms of helping a patient get through their therapy to get all the treatments that get them well. It's not uncommon that patients have to get rehospitalized, and that can be a burden to look after all of the issues at home while a patient is hospitalized unplanned. Can be really tough on couples, families.